So we have finished your exams. You all has finished your exams, and so let us assess how was our planning and how was our program gone, and how was the questions. I was able to get some questions from our students only, and there are around some 46 questions I was able to collect from some of the students, and I'm thankful to them for getting me the questions. And as these are questions which I got from the students, the options there are, I didn't get all the options for some questions. I got only 3 options. I had recreated some options, but altogether the theme of the question is what we are going to discuss, and this will be an eye opener to me as well as to you to have what all areas are important, because this is the first INI SS exam conducted in the history. So let us start with the modules we discussed and how much important questions came from, whether it was expected. Some questions were expected and some were quite unexpected questions came. So just we will go to and review our what all things we have covered and what were the important areas, and this may help in the next coming batch to go through the important areas, because it's the first time INI SS has been conducted. So coming to the questions, coming to the modules we discussed, we first discussed about approach to neurology, which is a basic module. Only the language, some areas we have discussed there, remaining was predominantly about how to approach and all those things. So there was no questions asked from the language area per se. But the sleep was the next module we discussed, and I had discussed a little bit depth into sleep, because the questions used to come from the sleep disorders. When we were doing the last round revision of neurology also, I told you that there are some questions that might come from the disorders, particularly narcolepsy. That also I had stressed during the last revision, narcolepsy is stressed. And some questions I was expecting from the drugs, but there was no question came from the drugs, but the question came from directly from the narcolepsy only, and that was expected. And peripheral neuropathy, there is again a in-depth we have discussed, but only 2 questions has came, and those 2 were rather one question was directly from our module, and the second question was it was looking little bit out, but that also we have discussed. Then the muscle, I expected quite a few questions from muscle, but that area was there was no questions literally, that whatever questions I got came from muscle. But that doesn't mean that that area is not important, because muscle, especially the DMDs, dystrophies, and the new drugs in DMDs, and then about the inflammatory myopathies, the antibodies in inflammatory myopathy. These are always the favorite questions of examiners. But this time there was no questions, unfortunately. But from Neuro which I had taken a little bit depth, and I expected few questions. There are 3 to 4 questions came from Neuro and 1 question came in the Neuro I had included another part also. So there are around 3 to 4 questions came from the Neuro section, and that was a little bit in depth questions came. And cognition and dementia, there are 4 questions came. And hyperkinetic moment, there are 3 questions, and 1 was regarding the drugs. And the most important topic was stroke. There are around 13 questions. Whether it is UG, PG or anything, always stroke and vascular neurology, that area is very important. Here also, they almost 13 questions came, and we have tried to cover stroke in depth. I had put lot of time in the stroke module, and as expected, lot of questions has come from stroke. But again, there are some 3 to 4 questions which are relatively new when compared to what we have taught, what we have studied in our modules. So that was slightly out of the box questions came in the stroke area, but you cannot tell that it is completely out of the box. So we will discuss into that later. Epilepsy, there are 4 questions, and headache, there are 2 questions. And epilepsy questions were little bit in-depth neurology questions, and those were practically totally out of Harrison questions came. And headache, 2 questions. Demyelination, there are 2 questions. And cerebellum and attacks, there are 2 questions. Spinal Cord, again 2 questions asked. Neuro Infection, there are 3 questions. Mnd and Nmg together, there was 2 questions, and we were expecting some questions from Mnd that we have discussed when we are doing the revision session also. What all things to revise also, we told that we have discussed that there a question may comes from the SMA related drugs, and same question came. The SMA related drugs is a new thing, and so the question has came from that area only. And CSF pressure is another area which we have not covered, but only 1 question that is relatively simple only. What is a normal CSF pressure? That is related to that question has come, and 1 question from genetics has come about the repeat disorder, and that also actually you can answer if you've gone through the modules we have discussed about in 2 places. Now with this we will go and first discuss about the epilepsy. There are 4 questions which came from epilepsy. So let us go to the epilepsy questions. The first question was a 2-year-old child with intellectual disability and episodes of atonia and falls, atonic falls and clonic movements. So what are the possibilities? Options given were Lennox-Gastaut syndrome or LGS, Douce syndrome, childhood absence epilepsy. The fourth was probably given as Dravet. Actually, that option was not clear to me. But anyway, the answer doesn't need all the option. So the question was, there is intellectual disability and 2-year-old child with intellectual disability and episodes of atonic falls and clonic movements. So when we have discussed this same disorder in the epilepsy, particularly in the epileptic syndrome, epileptic encephalopathy part 2 in our module. And LGS and Douce, the childhood absence epilepsy doesn't present atonic falls. Atonic falls occurs predominantly in LGS, Douce syndrome, as well as in some late onset West syndromes. So, Dravet syndrome is classically with the febrile seizures followed by febrile MAC. We have discussed in our module, febrile MAC, febrile seizures is onset, sesamic, pre-sesamic and all those things we have discussed in our module. So, Dravet is not the answer, and childhood absence epilepsy, it is not associated with atonic falls. So, atonic falls and clonic movement, the doubt will be between LGS and Douce syndrome. But this is from the module we have discussed about Douce syndrome, where there is no tonic seizures is one thing is highlighted, and along with that, when you discussed about the same LGS and tonic, LGS has tonic movement and myoclonic movement, and myoclonic is not there, a classical seizure type of LGS. So we discussed TADAPS, that is a code we discussed, TADAPS. So, tonic, atonic, atypical absence and atonic falls and P and S starts with paroxysmal fast activity and slow spike and discharge, that is we have discussed in our modules. So, a clonic predominant seizure, myoclonic or clonic predominant seizure never goes in hand with LGS. That we have rightly pointed out. I have told it during the discussion on epileptic encephalopathy in the LGS. When there is a clonic seizure predominant and falls, it is not likely to be LGS. So that was enough to answer this question, because the 2-year-old onset and there is atonic falls and clonic movements. Atonia doesn't occur in childhood absence, that we have discussed. Dravet syndrome starts with febrile, then followed by myoclonic, atypical absence and sometimes CPS or complex partial seizures. That was we discussed as a code, febrile MAC, and LGS and Douce is the remaining options, and Douce syndrome is something which presents atonia with myoclonus. But LGS, myoclonus or clonic seizure predominance is never a feature, there is tonic seizures are predominant. So the answer is Douce syndrome. So that we have discussed rightly in our modules, all these things, Douce syndrome, LGS difference, all those things we have discussed. And regarding the age, again in childhood absence epilepsy, you can see this is the same slide from our module. It is 4 to 10 years of age. So that is also something which goes against childhood absence. Dravet would start with febrile seizures. There is no history of febrile seizures. And atonic falls are not that common with Dravets. It is more common with Lennox-Gastaut syndrome, Douce syndrome, and as well as in late onset West syndrome. Okay, so the answer is Douce syndrome. So that is also discussed question. We don't need to understand everything to answer it. You just need to understand that atonic falls and tonic movement goes with LGS and clonic movement doesn't goes hand in hand with Lennox-Gastaut syndrome. So now coming to next question, it is also regarding childhood encephalopathy only. A 2-year-old child with history of febrile seizures and later on myoclonic seizures and the gene involved. So that is what we discussed just now. And we have discussed same thing in the module also. A febrile seizures followed by encephalopathy and myoclonic, that febrile MAC. Febrile MAC is a code we discussed. Febrile seizures followed by myoclonic seizures, atypical absence, and complex partial seizures. This is a classical feature of Dravet syndrome. So it's a Dravet syndrome. So what is ion channel related Dravet syndrome? That was also discussed rightly in our module. We have discussed that is CN1A. This was the same slide from our module. And same discussion, we have discussed that SCN1A, this is what discussed, SCN1A mutation is classical for Dravet syndrome. Actually, in fact, we have discussed it in 2 places. Once when we are taking the module in the Dravet syndrome, we have discussed the same thing. Then again, we have discussed about the different ion channels associated with seizures when we are discussing the MCQ in epilepsy. In that way, this is a table directly from Harrison. SCN1A is associated 80% of Dravet syndrome is associated SCN1A, and CHRN is associated autosomal dominant nocturnal frontal epilepsy, and KCNQ2 is associated benign familial neonatal seizures. So, and LGI1 was Lateral, ADPF, all these things we have discussed, and we have discussed about table regarding the channelopathy. In the channelopathy MCQ at the end also we have discussed one table where we have mentioned that generalized epilepsy febrile seizures associated with SCN1A, same gene is associated with Dravet also, that also discussed in the Dravet syndrome in the epileptic encephalopathy module part 2. In the timing also it is given here. So, that is the answer is SCN1A. So, that is also directly from our module. And the third question asked was GABA transaminase inhibitor. This was also, we discussed this straightforward, we discussed in the module that GABA, the module about anti-epileptic drugs in epilepsy session part 1, where we discussed that when there is vigabatrin we discussed. Vigabatrin we discussed that GABA transaminase inhibitor and associated with visual side effect. We had split it in a code and studied. The same question came. So, the answer is vigabatrin, GABA transaminase inhibitor, and we have discussed about gabapentin which act on the different channels, onisamide and phenobarbital which act on sodium channel. All these things we have discussed, and this was a snapshot of the same discussion where we have drawn that vigabatrin is associated with GABA transaminase inhibitor and which is again you can remember by VI stands for visual side effect. So, retinal changes or visual side effect is side effect of gabapentin, vigabatrin. Then is GABA transaminase, that is gabatrin. That vigabatrin is visual side effect, gabapentin, GABA transaminase inhibitor, that we have discussed. Same question came here. The next question was in fact directly, it was the same MCQ we have discussed in the MCQ session on epilepsy. The same question, almost same question we have discussed. Epileptic spasms findings are all except. That is a question asked in the SS, INA-SS, and it was like options are generalized slow waves followed by electrodecriminal response, and generalized polyspike and wave discharge, and spindle wave, possibly spindle wave. That is the fourth option, and I am not sure of the fourth option, but the same question was discussed, and this is directly from Harrison. The Harrison, it is not there in Bradley or other text, it is directly from Harrison, and this is a question we discussed in our module. In MCQ session we have discussed this module, that the EEG correlate of epileptic spasm in West syndrome is hypsarrhythmia, chaotic giant slow waves, and spike and wave. That is option we are given, and the answer is electrodecremental response. That is directly from the Harrison. And this question we have discussed a similar question, and this question is discussed. This is a question we discussed in the epilepsy MCQ module. So, the answer is electrodecremental response is associated with epileptic spasm, that is directly from Harrison. So, there were total, this was the reference we have given during the discussion, Harrison 20th edition, page number 308, that is this is there, electrodecremental response associated with epileptic spasm. That is a direct question which asked in the INA-SS. So, in the epilepsy there are total 4 questions asked, and luckily all the 4 we were able to discuss in the our modules, and I hope those who have gone to the modules as well as MCQ should have able to answer all those things, and you don't need to know the entire details of question. You can rule out by using whatever you have studied from your module or whatever you have studied by yourself. You can exclude the options and find out the answer. So, epilepsy all the questions were covered. Then coming to the next is the demyelination session. So, epilepsy all the 4 questions covered. Demyelination, there are 2 questions asked. The first was Wingerchuk criteria, and NMO, MS, Adam and NT-MOG were the option given. Actually, this was something which I have not discussed. Like, you cannot tell that it is I had not completely discussed. I have discussed the criteria, but have not mentioned the name of the publisher. And this is actually the NMO diagnostic criteria, which we have discussed in our module. And the name of the criteria or the publisher's name was Wingerchuk. The modified Wingerchuk is the latest one we are actually discussing in our module. So, the answer is NMO, and actually the question is not that tough because MS you have gone through the criteria, it is not the answer. And whenever you see such criteria, the most criteria you have studied is Wingerchuk. Some if you use little bit intelligence, it will be able to answer, but this was something which is we have not discussed. And now that is a realization for me that you have to go in depth about the criteria also. So, this was discussed in neuromyelitis spectrum disorder. This was a slide, and this criteria was been known as Wingerchuk criteria because this has been, the publisher is Wingerchuk, and so this was a criteria for diagnosis of NMO spectrum disorder with accoporin positive as well as accoporin negative. So, next question is which of the following is not a part of McDonald's criteria 2017 McDonald's criteria specifically asked, and this was something which I have discussed at the end of the, after discussing about McDonald's criteria, I wrote on the slide that there are three major differences of McDonald's 2017 and the old criteria. This is discussed at the time 4312. I had discussed and I wrote on the slide also that OCB inclusion, cortical and extracortical lesions are included, and the third one is symptomatic lesions in spinal cord according to the old McDonald's criteria were not taken, but the new criteria is included. These are three major differences of 2017 McDonald's criteria. So this also has been directly discussed in our modules. So the answers options were OCB included, that is actually not a part is the key word here. OCB is included in the criteria, cortical lesions are included, symptomatic spinal cord lesions are not included to categorize DIS or DIT. So this was wrong. This was the old criteria, old McDonald's criteria has not included the symptomatic lesions of the spinal cord are not included according to the old criteria. But the new criteria, there are three major differences in 2017 McDonald's criteria. Even if you don't study the entire McDonald's criteria, at least this is the most important part. OCB is included for dissemination time. Then cortical lesions were not included in the old criteria, but cortical lesions are included in the new criteria. And symptomatic spinal cord lesions are included in the new criteria, the spinal cord lesions, which was previously not included for counting the dissemination in space, but now it is included. So that is also directly from this, from our modules, and this was the McDonald's criteria, new McDonald's criteria. You have clinical attack and number of lesions with objective evidence should be there. If two clinical attack and you have to, your aim is to prove DIT and DAS, dissemination time and dissemination space. For dissemination time, the new McDonald's criteria has included CSF OCB. And for dissemination in space, previously the spinal cord symptomatic lesions were not included, but the new criteria is included. The third point is cortical as well as extracortical, both has been included in the new criteria. So that was the two questions which asked on demyelination. Both has been discussed, but Winkershoek criteria was not mentioned in our module. That was one question which just came out of the box or out of our module or whatever I have taken the classes. In that I have mentioned the criteria but have not mentioned the name of the criteria. So next time onwards I will try to go into the names of the criteria, those which are not. I thought it may not be like the name of Winkershoek may not be that much significant, but they asked directly from that area only. That was my mistake. So we have discussed epilepsy as well as we have discussed demyelination. Now let us go to the cognition and dementia. There are 4 questions came from cognition and dementia altogether. The first question was mesolimbic pathway act where acetylcholine, dopamine, glutamate and noradrenergic. And actually this I have discussed mesolimbic pathway, I remember like 3-4 times I have discussed. First when we were discussing about the wakefulness responses of the sleep, wakefulness circuit, I have orally told about that. Then second time when we are discussing about dementia also I had discussed about mesolimbic pathway, and I have drawn, this was the same diagram which I had drawn during the module in managing the Parkinson disease when we were discussing about the side effect of dopamine agonist. We have drawn about the reward circuit and median forward bundle mesolimbic mesocortical pathway. So this is a dopaminergic pathway which originates in the tegment of the midbrain and which ascend upwards, and it divides into two. One goes to the cortex and second one go to the nucleus accumbens or limbic circuit, and that is known as the mesolimbic pathway, and these both are dopaminergic pathway. So we have discussed about number of dopaminergic pathway also there. So that was again those who have gone through that module will be able to answer. That is dopamine is the answer. So mesolimbic and mesocortical pathway are part of dopaminergic pathway involved in the cognition as well as behavior response, and it is part of reward pathway. That also we have discussed about it. The next question was abulia points the lesion to which part of the brain? Median frontal, ventral pons, dorsal pons, and one more option was there. And abulia is actually amotivational syndrome. Amotivational syndrome can range from apathy, where the patient doesn't have much, doesn't come up with answers. And abulia means there will be some motor movements, but they won't answer. And akinetic mutism means totally akinetic. So these three are the spectrums of amotivational syndrome that we have discussed in lobar function of frontal lobe. In a cognition dementia session, we have discussed the emotive. This is the same slide, same screenshot from there. amotivational syndromes, apathy, abuli and akinetic mutism were associated with medial frontal lobe lesions? The answer is median frontal, because median frontal is a energization. Dorsolateral prefrontal is executive, medial frontal is energization, orbitofrontal is behavioral and personality. So the answer is easy, it is a median frontal, and luckily we were able to discuss the same thing in lobar function of frontal lobe, apathy, abuli, akinetic mutism when we are discussing on medial frontal lobe dysfunctions. Then NPH radiology, which among the following is false? And this was again one more area which is actually in depth of neurology has been asked, because this is something which is very important for a neurologist point of view, because NPH is a quite common diagnosis whenever there is a gait problem with urinary dysfunction. So apex crowding, sulcal widening, basal cistern effacement, periventricular seepage. So this also we have discussed in other forms, other dementias again cognition dementia section, the last module, other dementia. At the end, near the end, a last discussion was on NPH, where we have discussed the different signs. There are some about 11, 12 signs are there. We have discussed Evans index, we have discussed temporal horn dimension, periventricular seepage is there in the option. So that is true, this is true. Which among the following is false is a question. And the next one is next question is sulcal widening. So that was there here, widening of the third ventricle and sulcus. So there is something known as DESH, the disproportionate enlargement of the disproportionately enlarged subarachnoid space. So that is what is known as a sulcal widening. That means here you can see that there are some of the sylvian fissure and some of the subarachnoid space is very much wide and the sylvian fissure is wide open. But when you see the higher cut, you can see that the apex is totally crowded together. That is because a disproportionately enlarged subarachnoid space. Some areas are dilated, some areas are disproportionately compressed. So that is again the option given, apex crowding and sulcal widening. So those are again true. And basal cistern effacement is the wrong option given here. Even though you don't know the understand about what is basal cistern and all, if you know the NPH findings, you can answer the question. Basal cistern is a space around your ventricle, that is this area, the basal area around your brainstem, the pons and midbrain, perimesencephalic as well as the peripontine, and all those areas are known as the basal cistern. And NPH, it is because of the increased the imbalance of the flow and absorption of CSF is supposed to be the one pathogenesis, and where there will be the problems are happening in the cortex, not in the lower part. In the subarachnoid space, in the upper part of the brain is affected predominantly. So these are different signs we have discussed. These are same slides we have put in our modules, and this is a callosal angle, the narrow callosal angle, because this is callosal angle is one point you can differentiate in NPH from an atrophy. Because of the atrophy, when there is a severe atrophy of the brain parenchyma, they also looks like ventricles are prominent. So that is an extraocular dilatation of ventricles. The extraocular dilatation of ventricles can be differentiated from NPH by majorly 2 points. One is DESH, which we explained. Second one is callosal angle. You see here in the ventricle, here the CSF in the ventricles are applying pressure like this. In the case of an NPH, while here the CSF is normal in the case of a atrophy. This is an atrophy and this is NPH. So here what happens is the brain parenchyma has gone down like this because it is atrophied. So the angle, the callosal angle here is, this is the callosal angle, that callosal angle will be widened in the case of an atrophy. While the ventricles are filled with increased CSF, that will push the brain like this, and so there will be callosal angle become narrow or acute, as well as there will be a disproportionately tight apex, that is known as apex crowding, along with sulcus are prominent in the lower part. So that is known as DESH, or disproportionately enlarged subarachnoid space. So these two are two important findings. This is Evans index, that is a lateral hemisphere of the lateral ventricle. The frontal horn, transfrontal horn dimension is measured, and the maximum dimension of skull is measured. The ratio is known as Evans index. So Evans index more than 6 is another important question that can come in the coming up exams. So all those things we have discussed. So the answer is apex crowding, sulcal widening, periventricular seepage are seen in NPH. The wrong answer is the basal cistern effacement is the wrong answer. So that was also we were able to luckily that also we have discussed in our modules. So which is an incorrect match. Again, this is one area we have stressed multiple times during the revision session also. The newer drugs in neurology, especially the monoclonal antibodies and the antisense oligonucleotide group, those two are very, very important. And when we were taking the revision session, we told that Solgenesma or the onaseminogen epiproxoxy that is used for SMA is there in the limelight in the news, and nusinersen also there in the limelight in the news for a long time. And I have mentioned that these two they may not ask, they may ask the third drug, that is the risdiplam. Risdiplam is the only oral drug for SMA. That also we have covered and we have discussed in our module. So this is correct answer. Erinumab, migraine, there is another question came in the same question paper regarding erinumab. So the monoclonal antibodies and migraine that we have stressed multiple times, that is also very important. So erinumab has been true. And next two questions, so ocrelizumab is a newer drug approved for PPMS, that also we have stressed many times. It's the only drug, it is latest drug, it is approved for MS, that I have stressed once again during the revision session. And this is the question which is as aducanumab and headache. That is actually wrong, incorrect map, because we have discussed in our module for the treatment of Alzheimer's disease. In the module of Alzheimer's, see here, the monoclonal antibody is directed aducanumab, solanezumab, ganaxolizumab and crenezumab. Of this, aducanumab is only drug which is approved, just approved in 2020 for when I was while shooting for this module. Some few days prior to that shooting, only this got FDA approval. So and that is why I kept in the bold lines, because it was approved just luckily just before I was shooting for this module. Just few days prior to that, this drug was approved. And that news came in the newspapers and all. So that is that wrong option is aducanumab, which is not an anti-headache drug, which is directed against, it is used against Alzheimer's disease. So that is also luckily we have discussed, and this again stress you that the importance of the newer drugs, particularly antisense oligonucleotide drugs and monoclonal antibodies, and these two things and the latest approved drug, particularly in MS, is important. That is the importance of this question per se for preparation. So in cognition and dementia, there are 4 questions asked. More than what we discussed, it is important to understand that in cognition, there has been some questions came from the basic neurophysiology. That one question, mesolimbic pathway, was directly from the neurophysiology. Especially when you are studying about Harrison or medicine, these things are bit on the higher level. And the second thing, again, I want to stress is importance of Alzheimer's disease, particularly the newer drugs in neurology. Always for any neurology exam, go with the newer drugs, at least the name of the drug and the disease associated, especially monoclonal antibodies as well as the latest approved ASOs or genetic drugs. These two things are very, very important, and this stresses the importance of those areas. So I will tell in cognition dementia, again, it's a huge area. It's very important to read Alzheimer's, and NPH, of course, is important every year, but this time NPH MRI, they have asked in detail. Actually, this was little bit very in-depth question directly asked from the MRI of NPH. And then coming to the next session is we have discussed epilepsy, we have discussed demyelination, we have discussed cognition dementia. Now let us go to the headache. Headache, only 2 questions asked, and one question was as expected from the newer drugs of migraine, which has been there in the previous cognition. Also one option was come from that area only. So again, that's just the importance of the newer drugs. Then the next question was, the first question was, what is true regarding retinal migraine? Misnomer of migraine with visual aura, unilateral visual loss with or without headache, bilateral permanent visual loss and bilateral visual loss. Actually, this question was, again we have discussed about it, but the importance of this question is, this is one area everyone will have confusion. Retinal migraine, whether it is bilateral visual loss, whether it is unilateral visual loss, or whether it is an aura which is in, whether the aura which you see in visual aura you see, whether that is retinal migraine. This is one area where everyone will have confusion. So this was discussed in our module, and retinal migraine is attacks of reversible monocular visual disturbance with either positive or negative visual phenomena. So the answer was the unilateral visual loss with or without headache is answer, not a aura. Aura is not, or when you have visual aura, you will call it as migraine with aura. And bilateral permanent visual loss is never seen associated with retinal migraine. That is also the other loss. Bilateral visual loss is also, when you have bilateral visual loss, you cannot call it as retinal migraine or aura of retinal migraine. Even if it is transient, you call it as amaurosis fugax, because you have to rule out other proximal lesion. I mean, not amaurosis fugax, you call it as hypoperfusion because of the hypoperfusion of retina or the optic nerve is a reason. It can be either a presyncopal symptom or and all. But when you say unilateral visual loss without headache, it may be a retinal migraine, but again unilateral visual loss without headache, you should rule out an optic nerve head ischemia. So that was we have discussed it in migraine session. And then coming to the next question, Ernomab, which has come in the previous option also. We have discussed about the Ernomab, the CGRP related drugs, the newer drugs. This is a slide from our module. We have discussed about the drug, and we have told that it is given monthly injections, and we have told that the monoclonal antibodies targeting the receptor and target both are different. Because this can either target the CGRP directly, or you can block the receptor. Two groups of drugs are there, and oral drugs are GPANs, and these all things we have discussed, but we have not discussed that whether what are side effects of Ernomab. We have not gone through. But you can answer if you know the other things also, because it is given subcutaneous that we have discussed, and it will cause us, it is a CGRP antagonist that we have discussed, once a month injection also we have discussed. So the remaining option is hypotension, but we have not discussed about the side effect of these drugs. And post-marketing trial, it has been shown that they produce hypertension, not hypotension. And injection site reaction, constipation, cramps, muscle spasm, these are the side effects associated with this drug. So, and there are two questions asked in headache session, and out of that one question we have discussed. Second question, Ernomab, we have discussed, but we have never gone into the details of this much, which has been asked the question. But I think you can be able to answer, even if you can rule out the other options, so you can arrive at a final answer directly. But we have not discussed about that in our modules. About the side effect of Ernomab, we have not gone, but still you can able to answer it, because when you frame such a new question, the examiner who is setting the question also thinks the same way. If you keep the one option which is the answer, which is really tough, but other options, if you know, you can answer it, because you can exclude other options. So that is the same basic idea of answering this question also. If you know the other three options, you can exclude the three options and find out the answer. And so we covered that also, and then coming to the Mnd and Nmg, there are total two questions asked. One was, as we expected, the newer drug of SMA, that is nusinersen, has been asked, and the answer is SMA. That I think most of you will know it. And these are three newer drugs, and you see in the options they have asked about nusinersen directly one question, and one question they are asked about the slip-lamp. So, and this is a drug which has been in market, and it is there in newspapers now daily, almost in news it is coming about the costliest drug in the world, and it has been given into this child here, this child there. That is where they intelligently doesn't ask a question directly from onasemino provoked, but they directly asked from the other drugs, that is nusinersen, as well as they asked about a slip-lamp, and this is only oral drug. Okay. So we have covered it in one table also. We have put in the spinal muscular atrophy, SMN based therapy, how SMN1 based therapy and SMN2 based therapy. Nusinersen is only SMN2 based therapy. Others are SMN1 based therapy. That is also a possible question which may ask in the coming exams. So that is spinal muscular atrophy, and that was one question. Second question was congenital myasthenia with episodic attacks and familial infantile myasthenia is associated with DOX7, Rapsin, and CHAT and Agrin. This we have discussed in our module in the MCQ in congenital myasthenia. We have discussed the crisis is associated with either Rapsin, CChat, and fast channel. And when you come back to the option, these two are there, Rapsin as well as CHAT deficiency. But this we have discussed, C stands for crisis. So that means this severe attacks are associated with CChat, and childhood attack is associated with CChat. Adult also they will have CChat associated. Myasthenia will have crisis or respiratory failure. But Rapsin usually they will present with associated childhood crisis, high R's palate and arthrogryposis, but in adult life they won't have crisis. So crisis is predominantly CChat deficiency. That is, C stands for crisis is what we have discussed in our module. The question came from there. And NMG and Mnd, there are two questions. Both were we have discussed. But more important to understand is that in Mnd, now the most important area, the hot topic is SMA drugs. And NMJ, again, the congenital myasthenia is one area they will ask a lot of questions. So these two were expected important areas, and questions from that same area only. So there were actually, in fact, two questions will be able to answer if you know about the SMA drugs. One question was asked regarding which among the following drug is false. Aducanumab was and the answer there, but you should know that the importance of SMA drugs. Now coming to the most important and most high yielding topic for any exam, that is stroke. There are 13 questions asked, and there were 4 questions which we have not discussed. There are 4 questions out of the 13. So that is one area we need to, I think we need to know a little bit, go a little bit further. And this was the first question, was which among the following is wrong regarding risk reduction related to skin stroke. That is something like that. This question was not exactly what, not the same question, but the question was asked about the relative risk. All the options are regarding which among the following is wrong, relative risk and risk reduction are the options. And I am not sure whether these were the options asked, but the theme of the question was from this table directly from Harrison, which we have not discussed in a module. I have not discussed this in the module. Actually, I had taken in depth about stroke, but I have not discussed this table in our module. But Harrison tables are always important, and this was a question which asked from this table. So you should by heart this table. Related risk reduction of hypertension is 2.5, atrial fibrillation 1.8, diabetes is 1.8 to 0.6, smoking 1.8, and asymptomatic carotenosis related risk is 2. Highest, but these options I was not sure, and I got these options from the available options. Diabetes, warfarin, and smoking related risk are correct, but asymptomatic carotenosis, it is not 20%, it is 2%. But again, I am not sure whether this was exact question asked, but the question came from this table in Harrison about the risk factors of stroke. So again, stress the importance of the tables in Harrison's. Okay, and this was the next question. The patient with hemiparesis planned for thrombolysis, initial investigation of choice. Actually, this was the same thing we have discussed multiple times during this the management of stroke. I was stressing to the point that there is no need of MRI, there is no need of CT angiogram, there is no need of ECG also. Only 3 investigations are required. One is BP, second is GRBS, third is an imaging, which is plain CT, and one thing that is clinically NIH score. These are 4 things required for thrombolizing a patient. Nothing else is required. That has been stressed many times, and even I have framed a similar question in our Facebook page. I had put one question, and many answered that it should go for CT angiogram, and somebody has came with the Alberta. Some old guidelines which mentioned about need of CT angiogram, and so CT angiogram is option. And similar question is asked in INA. CET for PG also. So this is one favorite area because everyone is confused because each hospital has each protocol. But what AAN 2020 or 2019-2020 guidelines, they tell that only CT, blood pressure, and capillary blood glucose. These are 3 investigations which are required for thrombolizing a patient, plus a clinical NIH scoring and clinical diagnosis of stroke. That is enough. And if you meet the other contraindications and indications criteria are meted, you can take directly for thrombolysis. So the answer is NCCT, capillary blood glucose, and BP, and you don't need any other investigation. A plain CT, a blood pressure, a glucose. These are 3 things required for thrombolysis, nothing more. There is no need of CT angiogram. There is not at all a need of MRI for thrombolizing a patient. Your aim before thrombolizing is to treat the patient at the earliest. Don't waste 20 minutes or 15 minutes for MRI. And your aim is to just a clinical diagnosis of stroke and a contraindication indication to be mated, and you need to take a CT to rule out a bleed. That was the only thing you need, and this was directly discussed in our module in the acute stroke management, investigation, thrombolysis, and monitoring at 18 minutes. And next question was a young male with a gas. It was somewhere like this. It was actually the image also is not exactly similar. What I got from my students is that the question was a gastroenteritis young male with a seizure, and which among the following is false. And for answering this question, you need to understand about the image, some ideas of the image of the CVT. And from my students, what I got was the image has having a dense delta sign. Delta sign was there, empty delta sign. So this is something which it's not exact image. So you can see that it's a contrast image. You can see a bleed here, and this is a contrast here, and you can see the contrast is enhancing like this, and the central area you are seeing a non-enhancement. When you give a dye in the venous phase, the vein is supposed to fill with dye. Here in the center of the vein, there is a hypodensity or non-filling area, that is the thrombus sitting there, and this shape is delta, so that is known as the empty delta sign. And this empty delta sign means that we were discussing about CVT. and I didn't get the exact options which has been asked. I didn't get. One option was mannitol and glycerol was not indicated. Actually, that is true, because mannitol and glycerol is indicated only if there is edema. There is a minor, you may not need a mannitol and glycerol. Antiplatelets and anticoagulants is something which is to be given even if there is a bleed. That also we have discussed in the CVT when we are discussing aneurysm in MCQ session. Aneurysm we had made an MCQ. At the end we are discussing about CVT. There we have told that the different signs of CVT we have discussed, and then we have discussed in the last question we have discussed about the management of CVT, where I have stressed the importance of anticoagulation to be started at the earliest without delay, and antiplatelets is never the option. I didn't get the other option, but you need to understand the idea, basic idea of the question was to the sign of CVT, it is very important. The Md delta sign is very important, and the treatment, basic treatment aspect of CVT. So that is something we have discussed previously. Different signs we have discussed. This is a dense clot sign or dense dense vein sign because of thrombus in the straight sinus, and this is a plain CT. This is a plain CT where you can see that again hyperdense area over the posterior area, and that is not a delta sign. Delta sign is seen in contrast CT, and these two are images of plain CT. What you are seeing is a pseudo delta sign, and here is a code sign where you see the transverse sinus is filled with thrombus in the plain CT, and this is the same image which I kept there. This is empty delta sign in a contrast CT. So empty delta sign occurs in a contrast CT. Next question is a 40-year-old with a hemiparesis CT showing a basal ganglia bleed. The prognostic score include all except. This is one area we have not discussed. So ICH, intracranial hemorrhage, we have not discussed. That is eye opener for me. I'll try to make something out of this, and I will put some questions regarding this areas at least. And the site of bleed, age of the volume, but you all know this criteria because you might have used it in your casualties, and I hope that most people who are doing MD medicine will be able to answer most of the questions which comes from the IC bleed. You all know that what is the common site of bleed. You all know the ICH scoring system. So that was the one notion. I just didn't go in detail for the ICH. And this is ICH score directly from Harrison. The table is given below, which includes age, hematoma volume, intraventricular hemorrhage, infratemporal intraventricular location, Glasgow scale, and DESIN includes the time of onset of symptoms. So that is the wrong statement. Site of bleed is important, age and volume is important, because these two, intraventricular and infratemporal site of the bleed. This is age, this is hematoma volume, and this is Glasgow scale. So the option which is among the following is wrong, is actually time of onset of symptoms is wrong. And so that is one question which came from the ICH score, which we have not discussed. The first question also which we discussed just now was with something which we have not discussed in our modules. The mechanical thrombectomy, which among the following is false statement. Actually the exact options I didn't get, but they were regarding the indications and contraindications of mechanical thrombectomy, where they were given the option. That is what I got. So these are something which I got from whatever from the students I were able to get, and these were one options: can be done those within more than 6 hours, can't be used which is more than 4.5 hours. So mechanical thrombectomy is done up to 6 hours level 1, and after 6 to 24 hours also you can do. So cannot be used after 4.5 hours is a wrong answer. So that is the false statement here, because the question asked is also false statement. So the answer was that. Remaining were all true regarding indications. So this also we have discussed the slides, the same slides we discussed in our stroke module. In the endovascular therapy chapter we have discussed it, level 1A, level 2A and level 2B evidence. So 6 to 16 and 16 to 24 meeting known and diffuse criteria. We have discussed about known and diffuse also. And this was the goal of thrombectomy also we have discussed. So again this stress the importance of the indications, contraindication for thrombolysis and thrombectomy. These two are the favorite areas. So stroke management part is something which is very, very important for your exams. And I believe that the stroke questions in any question paper, they come from the practical areas. The ICS score is important for practical. The risk reduction is important for practical. The indication, contraindications are important for practice. In your practice, day-to-day practice, it is very important. So all these areas questions could come. Another is TAR score. That is also very important. ABCD, that is actually not ACD, it's ABCD score. ABCD is 2 score, Chatsworth 2 score, Aspect score, MRS score. So Chatsworth is for AF, and Aspect score is a CT score for thrombolysis. MRS score is a disability scoring used in the stroke. And this is ABCD 2 score is the answer, TA, which we also discussed. ABCD 2 score, again it is there from Harrison only. and this is ABCD2 score. A is B for blood pressure, C for clinical symptoms, D for duration, and D for diabetes. And ABCD2 score is a score which is used in TA, which we have discussed. ABCD2 score, ABCD2I score, ABCD2I2 score, all the possible scores, all the possible important TA scoring systems we have discussed in our module, and it was discussed in the stroke mechanism and pathology session in the stroke module. So again, this stresses the importance of practical scenarios of scoring. Practical scenario are being asked repeatedly in stroke. Then 75-year-old diabetic with a diabetic hypertensive with AF, not associated increased risk of stroke. Again, this is again the same practical scenario. So what they mentioned is a non-valvular AF. You have a valvular AF and non-valvular AF. Non-valvular AF is based on your CHARTS-VAS score, and valvular AF you will start anticoagulation based on certain other criteria. Valvular AF includes severe MS as well as mechanical replace. You can go with warfarin only, but non-valvular you can either go with neuro-oral anticoagulations or your plain warfarin. So this was based on the CHARTS-VAS score, which we discussed in the stroke secondary prevention in the stroke module, where we have discussed that C stands for CCF, H stands for hypertension, A stands for age more than 75, D stands for diabetes, and S stands for stroke, previous episode of stroke or TIA, and V stands for vascular disorders like PVD, and A stands for age 64 to 75, and S stands for female sex. So here the question, the clue was actually the question, it is a male. So the answer is the gender is not a risk, because stats was to score the gender, female gender is a risk, but male gender is not. Age 75 is a risk, diabetes is a risk, hypertension is a risk factor. So this is, you just need to understand the CHARTS-VAS score. So the practical scoring system, the TAA score, CHARTS-VAS score, aspect score, all these scoring systems are important in stroke. NIH score, again one more question has come. So all these practical scoring systems and studies are very important in stroke session. ICH score has asked. So this is a CHARTS-VAS and Hasblad score. You need to understand the Hasblad also, because this may be the potential next coming question. And all are thrombectomy trials except. This is one more area which we have not in depth, but I have stressed the importance of this when we are discussing the revision in neurology. I have told you to just remember the name of the trials of stroke and the name of the trials of MS. These are two trials which are very important. Just at least a name is enough in which it is used, whether it is thrombolysis, whether it is thrombectomy. That is enough. So next question is all are thrombectomy trials except. Actually, we have discussed in our modules about the thrombolysis trial, the chance trial, point trial, but we have not mentioned about the thrombectomy trial much. We have just briefly gone through some of the trials. And but when your revision module we are discussing, in that I have specifically mentioned to know about MR rescue, escape and all. And if you read this, if you have gone through Harrison tables, and Harrison at least gone through major trials in thrombectomy and thrombolysis, you will know escape, swift prime, MR rescue, all three are thrombectomy trial. So the odd one standing out is Hamlet, but Hamlet is a trial for decompression craniotomy in MCA in fact. There are many trials in decompression. One is Hamlet, second is Destiny trial. These are important trials. Then there are certain hypertension trials like Stitch trial and all those things. But you don't need to go into that detail. Actually, this question also framed in such a way that you need to know the basic thrombectomy and thrombolysis trials. And if you know the thrombectomy, the landmark trials, then you can answer the question by telling that Hamlet is something which is odd here, even if you don't know what is Hamlet. So such questions are always framed like that. You don't need to study all the trials, but whatever there in the Harrison or whatever there in the important major trials, you study it. And if some other questions come in out of the box, you can answer it with whatever knowledge you have by eliminating the options. So these are the thrombectomy landmark trials of thrombectomy trials are MR clean, extend IA trial, escape trial, swift prime, revascat, therapy, thrash, piste. These three things are not there in the Harrison. There is no need to study that also. If you know the name, it's well and fine. But at least remember MR clean, extend, escape, swift prime, revascat, and dawn and diffuse. This we have discussed in our discussion also. The MR cleans, extend, escape, swift prime, and revascat. These are the four trials, or 5 trials which are mentioned in the Harrison also. Even the old Harrison also it is there. They're the landmark trials. The new landmark trials are therapy, thrash, and piste. At least from the name of the trials and where it is in thrombolysis or thrombectomy, that is enough. No need to go into further details. The questions will come in that area only. And the trials of altiplase or thrombolysis, important trials are NINS trial. This is very important because this is the first trial which proved the efficacy of thrombolysis in first 3 hours. Then came the Atlantis trial, and it also studied up to 3 hours only, but it doesn't prove that it is more than 3 hours, it is not useful. And ICAS 1 and ICAS 2 are also studied to extend the life of thrombolysis, but ICAS 3 has proven that the significant improvement of clinical outcome in 3 to 3.5 trials. This is one important question that can asked. So other trials, NINS is something which proven less than 3 hours. So 3 to 4.5 that's just proven by ICAS 3 trial. Okay, that is one more important thing. So these are two trials you should at least remember. NINS, Atlantis and ICAS 3 is very important. And in patients wake-up stroke, the stroke investigation with thrombolysis is also a newer advancement which came in 2019 guidelines, which we have discussed, a new update on the guidelines for wake-up stroke. Previously, wake-up stroke were not thrombolyzed, but a trial known as wake-up trial come up, and in that trial, it has also discussed in our modules only. In the module of stroke, we have discussed a checklist for indication, same slide. Age more than 18, clinical diagnosis of stroke, disabling and onset more than 4.5 hours. And it's a new entity which come up in 2019-20 guidelines, that is unknown onset with diffusion flare mismatch. So when there's a wake-up stroke or a unknown onset, you do a diffusion flare, and if there is diffusion remain showing infarct, and flare there is no mismatch, and there is nothing is in the flare, or flare is normal, you can take it for thrombolysis, seemingly because they thought that diffusion restriction will start coming even within half an hour of a onset of stroke. But flare image, the changes appear by around 4 hours. So if you have a diffusion restriction is there, but flare is normal, that means the window is between 4 and around 15 minutes or half an hour. So that means that you can take it for thrombolysis. If flare also has shown hyperintensities, that means it has crossed 4 hours. So then it is risky to thrombolysis because you don't know whether it is crossed the window period of 4.5 hours. So diffusion flare mismatch is the answer. CT is used for other patients. Perfusion scan is not needed if it is less than 6 hours. Even if you are taking for a thrombectomy less than 6 hours, there is not a perfusion scan that we have discussed in our module. CT angiogram is not an emergency investigation, you can do it later. So the investigation required for diffusion wake-up stroke is diffusion flare mismatch, because the same wake-up study which uses same modality to thrombolyze. And so that is a fourth indication, it's a newer indication, again it's a newer updates. This is other indications and contraindications which we have discussed in our modules. Then coming to the next question, that is lateral medullary syndrome. And till now the questions what we discussed in the stroke, the importance of the scoring system as well as the latest updates. So that is already there, which we have discussed in our modules also when we told the newer updates which are not there in Harrison and which is coming up late. So newer updates and the practical scenario management is very important in stroke. Then lateral medullary syndrome, which is true. This is actually a tricky question. I feel it is very tricky because the option I got is this one. One is same side pain and temperature loss, opposite side face numbness, contralateral ataxia, downbeat nystagmus. Actually, we have discussed lateral medullary syndrome in brainstem syndrome part 2. I'll tell once again. You have brainstem, any brainstem structure, you have midline 4 structures, and laterally on the side there are 4 structures. So ES stands for side and M stands for midline. Midline you have structures starting with EM, that is MLF, medial longinal fasciculus, medial lemniscus, and you have motor fibers or pyramidal fibers, then motor nucleus of certain cranial nerves. So those cranial nerves are multiples of 12, that is 3, 4, 6 and 12. All these comes in the midline. All other motor nucleuses comes in the laterally. So on the side you have S, that is 4S. One is spinal nucleus of fifth nerve. Then you have spinothalamic pathway. Then you have spinocerebellar pathway. And you have the fourth S is the sympathetic pathway. And plus other motor nucleuses. These are there in the laterally in entire brainstem. So 4M in the midline and 4S in the laterally. This we have discussed in our brainstem also. So when you come to the lateral medullary syndrome, in the medulla you have the lateral cranial nerves. The medial cranial nerve is the 12 which comes in the medulla. So 12 is unaffected. So you take the pain and temperature is carried by spinothalamic, which crosses the spinal cord and goes there. So if suppose I am having, this is the right side, suppose I am going to have an infarct which happens to be occur in my right side, right medulla. So it should affect my right sided spinothalamic tract which carries input from the left side. So opposite side pain and temperature, so that is wrong. So then comes the opposite face numbness, again that is wrong because this side spinal nucleus will be affected of the fifth nerve, so same side, so that is also wrong. And the ataxia, again, the spinocerebellar or the crossing cerebellar fibers are affected. So it will affect the ipsilateral. Ipsilateral ataxia is associated with, not the crossing fiber, ipsilateral ataxia is associated. So all these were absent, these were wrong. So the nystagmus can present lateral medullary. So that is a probable answer. But the problem here is, again, what I got from 2-3 students is same, they all told it is downbeat nystagmus. But when you think in the view of a neurologist, you open braces, you will see a lot of variants of lateral medullary syndrome, where you can have same side face and same side body sensation. You can have opposite side face also. So if you take into that aspect, there are multiple true answers. You can have any type of lesions in lateral medullary. And downbeat nystagmus per se, braces tells is, downbeat nystagmus to affect, you need to get affection of medial and general fasciculus, which is located in the midline. So lateral medullary syndrome can present the horizontal nystagmus, also an upbeat nystagmus. Downbeat is not common. So in fact, this question, if you take in detail as a neurologist point of view, there you cannot find an option. So you cannot find an answer, because all are either true. I feel like all these three are true, and I feel this is wrong, if I take in a neurologist point of view. But if you think in a physician point of view, and if you think at the MT level, you don't go into the variants, just take the classical lateral medullary. In the classical lateral medullary, the same side pain and temperature, opposite visual numbness and condylar ataxia is less likely to occur. And you can have a downbeat nystagmus. You can have a nystagmus, and if there's a slight extension midline, you can have downbeat also. So I feel this is an ambiguous question for me, but I feel the answer what the examiner might have meant was downbeat nystagmus, just if you know the crossing of fibers. Because on MT level, you are expected to know the crossing of fibers, and you are expected to know the plain lateral medullary syndrome, not the variants. So if you account that, the true statement should be downbeat nystagmus. That is what I feel is. And this is what is discussed in brainstem syndrome too. The vertebral artery more than pica is more common. Ipsilateral fifth nerve, ipsilateral 7, ipsilateral 8, and ipsilateral 9 and 10. So ipsilateral 8 will produce vertigo and giddiness, and vertigo and giddiness, even nystagmus horizontal. And sympathetic will produce ipsilateral honors. And spinothalamic tract of opposite is affected, so contralateral sensory. ICP of ipsilateral is affected, so ipsilateral cerebellar ataxia. And hiccups and diplopia can occur. And parasympathetic affection will produce hypotension, erectile dysfunction and all. And the medial midbrain syndrome, you will have the medial structures. So the MLF is affected and produce upbeat or vertical or downbeat nystagmus can present with MLF involvement. So I think the probable option will be downbeat nystagmus. Okay. Then coming to the next question, primary CNS angiitis, which is not true. Actually, we have discussed about the primary CNS angiitis. When we are discussing about the classification of stroke at the end, we have discussed that vasculitis as a cause of small vessel disease, and where we discuss a primary CNS angiitis, we have stressed the point that they will not present with, they will present headache and altered sensory is more common, and they want the stroke per se bleed or infarct is less common. So these two, you can tell that these two are correct, but you will be confused between these two, and we have not discussed this in details in our modules. So actually, primary CNS angiitis occurs more commonly in males, not females. And primary CNS angiitis, MRI is almost 90-95% MRI will be abnormal. If a normal MRI almost rules out it, because MRI, you may see some white matter abnormalities. That is a basis of suspecting a primary CNS angiitis. Plus, and they usually present headache and confusion, altered sensory and all. And stroke, bleed or infarct is very less. So men are more common, it is 7:3 according to Medscape, and 4 to 6 decades is onset, and headache, confusion and are the common presentation, and stroke and bleed can occur, and MRI is abnormal in around 90% of location, and criteria, just remember the name of the criteria which is come in the latest broadly. So this is a possible another question which can come, because they are more interested in these criteria. Calabrese criteria, which you just remember the name, that is enough. And unexplained neurological deficit with evidence, or either classiographic, angiographic, unexplained headache, unexplained neurological deficit with either pathological evidence or other classic angiographic or histopathological evidence of angiitis and CNS, and there is no other systemic vasculitis or other explainable causes. That means that for a primary CNS angiitis, you need to get a brain biopsy or an angiographic evidence with an unexpected neurological finding, and the gold standard is biopsy. But you don't need biopsy for diagnosis always. But other causes, including other systemic vasculitis, SLE, everything, APL, everything has you ruled out. You cannot call it as primary CNS vasculitis if those are positive. You have to call them as secondary CNS vasculitis, secondary to APLA, secondary to SLE, like that. Okay, so that was a question which is not much discussed in our modules. I had just gone through that very briefly. So this another question is again a pakka practical question which asks is NIH score. NIH score is very important score for a practical purpose. So what is a question asked in NIH score? Again, this is for those who have practiced asking NIH score. Otherwise, you will be difficult because it will be confusing to remember, and you will not revise these details of scoring system before exam also. So those who have used the scoring system during the 3 years of the MD, they will be able to answer it. So the options are name and time, name and month, name and age, month and age. Actually, this has been discussed in an acute stroke management. I had shown the NIH score table also, and you can see here the level of consciousness, age and month is asked, not name, because name, nominal aphasias will hamper it with it. So age and month is asked. So the answer option here is age and month. That is the last option. That is what is there in the NIH scoring system. No other questions are asked. For level of consciousness asked by calling the patient, waking him up, alert or conscious. Second level of consciousness 1, A, B and C is there. A is for level of consciousness, B is for level of consciousness by asking questions. The question asked is age of the patient and month of the birth. And what is a month is the question asked, and level of consciousness will be open and close your eyes and grip and release your hand. So that is a question asked here was there from the NIH score. Is a very practical question which is for those who have practiced using NIH score only will be able to answer. That is what I believe it. So that was a question. And next question, other total 13 question came from stroke. The next question was false statement regarding thrombolysis. Again, the options I am not sure with it, but the option which was false, and that is the answer, is a tenecteplase not approved in India. Actually, tenecteplase is approved in India, and we have discussed about it in our stroke session also. A wake-up stroke can be thrombolized by diffusion flare mismatch and platelet SN1. Like this is actually, I framed these options because I didn't get the other options from the students which has given me. But some of them told that this is the, and this was the wrong answer, wrong option from all the given below. Remaining everything was regarding some indication and all, regarding was true. So question was tenecteplase was not approved in India, so this thing. And I think the examiner was pointing towards the latest update again. So other fibrinolytics, tenecteplase has been approved even in Indian guidelines, so 2019 stroke guidelines as well as the ACAHA guidelines, which proved that tenecteplase can be used. There are two doses of tenecteplase, which is 0.25 and 0.4. This is the same slide which we have discussed in the acute stroke management investigation thrombolysis at the time given below in our module. So tenecteplase is approved. There are two doses that have been approved. Those with minor stroke you can give 0.4, and those who are taking for thrombectomy, it can be preferred by giving 0.25 mg per kg maximum dose. So in the stroke module, again stroke is very important module because the bulk of the questions came from where 13 questions, out of their 4 were not discussed. CNS vasculitis we have discussed partially, but there is a detailed question asked. Remaining everything actually were very practical questions. So very practical and latest updates. These are the two areas which they have asked entirely in the entire question paper. The newer questions, difficult questions were all from the practical aspect as well as from the updates. So the next was ICH score, again directly from Harrison. Again Harrison tables are very important. Trials and relative stroke reduction score. Again, so you need to understand the importance when you're reading the reading any session. The new updates are important, and the practical scenarios, especially stroke, which is a very common case for any medicine fellow. So these the practical cases and the common scenarios, they will ask the practical things. That is the take home message for me. And now coming to peripheral neuropathy, 3 questions were asked. First was AL amyloidosis causes all except, and we have discussed about this multiple times. One, when we are discussing about the familial amyloidosis, we had just briefly gone through that. I had not discussed in detail. Somewhere in the peripheral neuropathy, I remember like while discussing about other neuropathy, just as mentioned about that, hereditary neuropathy, just as mentioned about that. But when we discussed about other neuropathies, in the MGUs, we have discussed AL amyloidosis has been seen associated with all the monoclonal gammopathies, and we told that I have told that they are present with a male patient of the CTS. Young male CTS always suspect the possibility of a amyloid by ruling out a small fiber symptom. That is what I specifically told. So autonomic neuropathy, small fiber, that is very common with amyloid. Length dependent sensory motor neuropathy can occur. Lumbosacral radiculopathy can occur. But AL amyloidosis we have discussed in the context of peripheral neuropathy. And amyloid angiopathy we have discussed in stroke. Amyloid angiopathy occurs because of A beta 40 deposition. We have discussed. In Alzheimer also we have discussed A beta 40 and 4140. So that has nothing to do with AL amyloidosis. So the AL amyloidosis is predominantly peripheral nerve disease, not a brain, doesn't affect brain. So AL amyloidosis is from reference is from this reference is actually from Bradley. It affects all the individually, commonly affect either individually or together in kidney, heart, liver and autonomic nervous system, peripheral nervous system. CNS is not mentioned. So stroke is not associated with AL, but stroke is associated with A beta 40 amyloid, the amyloid angiopathy. Both are different entities. And familial amyloidosis is also present with predominantly as a peripheral neuropathy. So we have discussed about the different manifestation of AL amyloidosis in other neuropathies. We have discussed they present CTS, they present with small fiber neuropathies and other neuropathies. Whenever a young male present with a CTS, there should be a possibility of this also should be considered and should be evaluated, especially for autonomic neuropathies. So autonomic neuropathy always amyloid is one thing we have to evaluate. And this was a table, this was a chart we have discussed about other neuropathy. I am not going into details. In that all the monoclonal gammopathies can present with amyloid-like presentation, and we have discussed that they present with CTS and peripheral neuropathy. So AL amyloidosis, this produces CNS affection, it produces predominantly stroke. And this was a bit out of the way we have not discussed about in detail about AL amyloidosis in our modules. And the next question was which of the not the nerve supply of urethra. That was an interesting question, because you may think that this is something which is very new, but it is actually in fact not new one. This is a practical question again. We have discussed about neurogenic innervation of bladder. In that we have told that bladder innervation, sympathetic, parasympathetic, somatic and a higher center control. You see the hypogastric nerve supply sympathetic, parasympathetic by pelvic splenic and somatic by pudendal nerve. And we have shown the same figure in that, and you can see that pelvic splenic supplies the internal sphincter, internal urethral sphincter, and you can see the hypogastric and vesical plexus which supplies again the internal urethral sphincter, and pudendal nerve somatic which supplies external urethra. So that is urethral sphincter is part of urethra only. So question is directly from the bladder. If make it simple, it is directly from the bladder. So pudendal nerve supplies us, hypogastric nerve supplies us pelvic splenic. Iliolingual has nothing to do with the urethra. It is just something which comes in the lower part of the abdomen and the perineum area. So it has nothing to do with the urethra. So the answer is ilioinguinal. It is actually in fact simple question. Even if you don't know the supply of ilioinguinal, if you know the bladder innervation, you can answer this. So that is actually discussed from our question. And second question is actually in fact directly from our module on the upper limb nerves. In that, even in the revision as well as how to prepare for NEET, I have mentioned specifically that these signs are very likelihood to ask. And I had told that during the revision, when I attempted the DNB exam, they have put a Fromet sign, similar figure of Fromet sign, and asked what is this sign and which nerve. Same question came here, and they have put the somewhat, it's not exact image, somewhat image like this, and asked which nerve is affected, and this is an OK sign. So we have discussed about it when we are discussing an upper limb nerves. You can see that this is a same drawn by me during the discussion. So that is OK sign, that is associated with the median nerve, and that is anterior interosseous nerve is a branch of median nerve, posterior interosseous nerve branch of radial nerve. Ulnar nerve has nothing to do. The OK sign is because when you hold like this in OK position, you need to flex the flexor pollicis as well as the distal phalanx. So these two are supplied by median nerve by the anterior interosseous nerve. If this is weak, you can show like you cannot flex, you can just hold like this, you cannot able to, you can see here this is straightened here, and here you can see the bend is very sharp here, but here you can see it is more or less flexed. It is flexed interphalangeal, first interphalangeal, distal is not flexed. So that is a classical feature of anterior interosseous nerve, because distal interphalangeal joint is affected as well as the FPL is affected. So anterior interosseous nerve is the answer. The sign is OK sign. I am not sure whether exactly this question was asked, but it was the OK sign which is kept for the exam. So OK sign we have discussed in upper limb nerve in our modules. So peripheral nerve, 3 questions asked, all were discussed, but I will tell that AL amyloidosis was little bit out of the box and we have not discussed that much detail. But if you know that we have discussed it in the peripheral nerve, that is enough to answer it, because We have not discussed AL amyloid in the stroke. Stroke we discussed is A beta amyloid deposition. That is different one. So that was about the peripheral nerve. Now going to hypokinetic and hyperkinetic disorder. Total 3 questions asked. The first question was, which I has been stressing during the module as well as during the revision session. I have told that newer drugs are important in Parkinsonism. Again, I have stressed about safinamide, I have stressed apomorphine, roticotin, opicapone. All these were in the option. And MOA-B inhibitor safinamide. Safinamide is not, there is no U. So safinamide is an MOA-B inhibitor, which has been discussed when we are discussing about management of Parkinsonism. You can see that I have written on my own handwriting this safinamide. So safinamide is a newer drug which is been approved, and it is again stressing you whether we have discussed or not, that is nothing a matter. What is important is again stressing you the newer latest approved drugs is always whatever is a neurological disorder, that is very important. So always go and revise before the exam the newer drugs, and especially monoclonal drugs, especially the anti-ASO drugs. So those genetic drugs and newer drugs always revise before exam. This again stress you the importance of that. Okay, isidrafil is another new drug. All these things we have discussed in the management of Parkinson's. The next question was again 21-year-old female, the dystonic posturing, behavioral symptoms, and I have mentioned that whenever there is a young patient or any patient comes with behavioral or dystonic symptoms, generalized dystonia, always rule out Wilson's. And if you see the options also, it is clear. It is an autosomal. Which among the following is true? That is the question. Autosomal dominant inheritance. Wilson's we have discussed. We have discussed that it is an autosomal recessive. I am not going into the actual image. Image was kept. Even if without image you can answer it. Image kept as something like a panda sign was kept, and actually we have not discussed about images of Wilson. That is actually something, it's an eye opener again for me. You have to go in detail about the MRI images. We have tried to put almost all possible images in the different modules, but this thing actually we have missed it, and I think I have told the image, I have not shown the image. And autosomal dominant inheritance, that is wrong. Even if without this you can answer it, because I have mentioned that dystonic posturing, generalized dystonia, always rule out Wilson's. And it is autosomal recessive. Dietary supplement of copper, because copper depositing disease, you are not going to supplement it, you have to restrict the copper. That is wrong. This is true, because restrict copper is true. And this is something which you all will fall for, because genetic defect of copper transporter protein called ceruloplasmin. It is not a ceruloplasmin defect, it is ATP7B defect, and that will reduce amount of ceruloplasmin. Ceruloplasmin gene is not affected. The answer is restricted copper, and what you are seeing here is a panda sign. So there is two signs. One is face of giant panda and double panda sign. Giant panda is something you see in the midline, in the midbrain, where the eye of the panda is formed by the red nucleus, which is here. The red nucleus is hypodense, that produces eye of the panda, and the ears are produced by the preservation of signals of the pars reticulata. Ears. This is a substantia pars reticulata which produces the ears, and the chin is produced with a low signal intensity of superior colliculus. So this is a chin. Chin is produced a low signal intensity of hyposignal intensities of superior colliculus. So that is the panda sign. You will see the panda sign where? Panda sign you will see in midbrain. While the miniature panda sign or club panda sign is seen in the pons. So there are these two panda, similar sign is seen in the pons. These two panda together it is known as double panda sign. So one panda sign is seen in the midbrain, and second panda, smaller panda, is seen in the pons, and this smaller panda plus bigger panda you will call it as double panda sign. So these two signs, especially panda sign, is very important in the context of Wilson disease MRI. They will keep routinely panda sign or bright cluster. These two are very important. So that was the giant panda sign. Second sign is miniature panda. That is seen, actually, just remember, it is seen in the pons. So in the pons, miniature panda, and in the midbrain you will have giant panda, together known as double panda sign. Another sign is a bright claustrum sign. You can see the claustrum is hyperintense on T28. So that is the three signs of your Wilson disease. So that is one question. Actually, even if you don't know the MRI, you can answer the question, because there is a dystonia and the options are all regarding the Wilson's. So the Wilson is a basic question. I think most of you will be able to answer even if without MRI. And next question asked was example of complex tic. This is actually again something which is quite difficult question for me, but for MD level it will be easy, because in Harrison it is clearly mentioned. The options were sniffing, shrugging of shoulder, hand movements and shaking. So this is a statement from Harrison. Complex tics are with coordinated movements of multiple muscles, latest Harrison. Jumping, sniffing, head banging, echopraxia. So sniffing is given in Harrison as a complex tic. But in American Association of Neurology, the Continuum Journal for Movement Disorder 2019, they had mentioned that simple vocal tics includes grunts, barks, flutters, moans, groans, sniffs and throat clearing. So vocal simple tics, they are conclude sniffs as a vocal simple tic. But according to Harrison, sniffing is a complex tic. So you can go with sniffing is a better answer, I feel. Shrugging of shoulder is simple, hand movements is single, hand shaking is simple tic. A complex tic is something which includes coordinated movements of multiple muscles. So sniffing is movement like this, so it's a coordinated movement of something like it's more complex and coordinated movement. So the answer is a complex tic. And this is also, I have discussed in a module as sniffing as a simple tic, but that is a motor simple tic I had mentioned, because I just gone to the reference of the Continuum Journal. But when I've gone to the Harrison, they had mentioned that sniffing as a complex tic. So the answer is complex tic. So hypo and hyperkinetic, there were 3 questions. Out of that, one was regarding the newer drugs, afenamide expected. Second was Wilson's expected. And Wilson's actually, even though slightly out of the box from our modules, but it is easy and you can answer it. The third question was again, actually it was easy, but there was little bit confusion regarding the option for me at least. So I will regard as 2 questions are probably out, but you can answer still all the question. But the importance again stressing hypo and hyperkinetic, again stressing the importance of Wilson's is very favorite topic, favorite area of all the examiners, and most of you will be well versed with the Wilson's. So Wilson's, there is nothing, I think there is nothing much to confuse in Wilson's. And second is a newer drugs of Parkinson's, that is again very important. Okay. So that was about hypo and hyperkinetic disorder. Next is we will go to discuss about one genetics related question came, which was actually I didn't get the exact question. The question was the following: is a pentanucleotide repeat? That was a question. And options, one more option which is probably the answer, which I exactly don't know. The option I didn't get, but you can answer it without even going into this. We have discussed in our module 2 times. One we have discussed when you're discussing about hyperkinetic movement disorder and MCQ discussion. Second time when discussing about dystrophic myotonia, we have discussed this, like trinucleotide repeat disorders. Trinucleotide repeat disorders can be divided into poly-Q and non-poly-Q. Poly-Q means those with CAG repeats, and those without CAG repeats are polyglutamine disorder. So this, if you know the trinucleotide repeats, you see DRPLA, Huntington's are trinucleotide repeats. You can see there DRPLA is there in the poly-Q repeat. Huntington disease is a poly-Q repeat. Non-polyglutamine, that is non-CAG triplet disorder. This is a triplet repeat disorder. All these are triplet repeat disorders. So this includes Friedreich's ataxia, myotonic dystrophy type 1, that is CTG repeat. So that is MD1. So the fourth option which is supposed to be there, that might be the answer. Even if you don't know the pentanucleotide, you will be able to answer. If these were the 3 options which is given, which is what I got. And when you come to this is the same slide which we have discussed in the cerebellum, ataxia and cerebellum. In that, the hereditary ataxia, autosomal recessive, at the end we have discussed this slide, where you can see that CAG repeat ataxias includes SCA1, 2, 3, all these are exons, SCA12, and you can see that this is a pentanucleotide, SCA31, then SCA10 and SCA37. So like that you can add, and SCA36. So I don't know exactly what was other option kept, but still you can easily answer that if you know that is a triplet disease repeat disorder, because triplet repeat disorder is something which you remember, and SCA10 obviously you have to study, and if you had gone through these modules, I think you will be able to answer, but still I don't know exactly what is the options, but the question was pentanucleotide repeat. So that again stresses the importance of genetics in neurology. So these are repeat disorders which we have gone through multiple times. So in the hypokinetic, hyperkinetic, there were, in the genetics, one question asked was pentanucleotide repeat. I think it is not a tough question if you know the other option. So again, the genetics in neurology, you have to revise the repeat disorders, you have to revise the different mutations, you have to revise, because they will ask a lot of questions from genetics. Genetics is very difficult and very important in neurology. An MCQ point. So next question we will discuss about neuro-ophthalm. There are some 3 questions asked. First was junctional scotoma is seen. Junctional scotoma we have discussed in a neuro-ophthalm session, optic nerve. We have discussed that there is a Wilbrand knee which comes the nasal, which can slightly go into the opposite nerve and come back. So a lesion in the distal part of the chiasma and optic nerve junction, if there is a compression, they can produce a optic nerve damage of the left side, that will produce left central, and the damage of the nasal fibers which carries a temporal vision, so it will produce a lesion like this. That is known as junctional scotoma. My students has told that junctional scotoma is something which is kept there. So glaucoma is not the answer. Pinealoma, which pineal gland is located, if this is a corpus callosum and this is a brain, the pineal gland comes here, posteriorly. So pinealoma has nothing to do with the chiasma, the anterior part of the chiasma optic nerve lesion. The confusion between optic chiasma lesion and diaphragm cella meningioma. And I have mentioned also that the diaphragm cella meningioma or the meningioma compressing the optic nerve and chiasma junction is a common cause for this. So the answer is diaphragm cella meningioma. If that was the option kept, this is what I got the options are. So question was altogether the theme of the idea of the question is junctional scotoma, to understanding about junctional scotoma, which we have discussed in the optic nerve session at this timing, and we have drawn this figure also how to make out junctional scotoma. So that was a direct question, more or less application based question. And AON, which is true, we have discussed about ischemic optic neuropathy, a separate module. When I was keeping that module, I was thinking that whether this was so important for medicine, but when I gone back and into certain areas, I find out that it is one of the common clinical picture you will see: acute onset of visual loss, AON versus arteritic and non-arteritic. So I had included ischemic optic neuropathy, a separate session. Steroids can bring the complete visual improvement. Visual loss, which of the following is true was the question. Visual loss is in the vertical meridian and optic disc is hyperemic, and I didn't get the, actually I got only 2 options. I didn't get the next 2 options, I didn't get. But the question was altogether from ischemic optic neuropathy, anterior ischemic optic neuropathy, and it was the question was about arteritic, that is what I got, arteritic anterior ischemic optic neuropathy question, and whether it is arteritic or non-arteritic, steroid won't bring the complete vision loss. Vision improvement won't be produced with steroid, but it will reduce the progression. And if you know about the visual occurrence in the vertical meridian, is actually true because it is altitudinal hemianopia. Altitudinal visual loss, that also we have discussed. A curtain like vertical meridian visual loss, that is something which, if you know that ischemic optic neuropathy will produce vertical, that is enough to answer this question. So visual loss occurs on vertical meridian, and this option I am not sure whether this was the option, because I got was that it was arteritic ischemic optic neuropathy is what I got, but I am not sure about the option. But the true statement should be a visual loss occur in the vertical meridian, because it is the most simple thing among all together. Like in a practical, it's again a practical point of view question. Whenever a patient comes to altitudinal visual loss, you should think of ischemic optic neuropathy. It is again a pure practical oriental question. And again, the junctional scotoma is also a practical oriental question. When the visual field is like this, you should think of a mass lesion compression optic nerve and the chiasma junction. So this was a difference of NION from AON, arteritic and non-arteritic, and arteritic is mostly in more than 60 years and non-arteritic more than 50 years. Non-arteritic is more common. These all things we have discussed in the module, but for answering this question you just need to understand that this occurs in altitudinal hemianopia, which is vertical meridian. That is the only thing you need to know. So there were the next question as a 40-year-old female, headache, blurring of vision, pupil bilateral sluggish, reacting over 6 days. And vision loss was over 6 days, and with image of the fundus was given. I am not sure what image was given, but I personally feel for answering this question doesn't need an image, because there is a visual loss. That is something which is going against optic nerve drusen. Drusen producing an acute visual loss is less likely to have. And the image what I got from my students was that is optic neuritis image was kept. But even if without that you can answer, because papilledema also doesn't produce visual loss like this in 6 days. So that too are not the option. Blurring of vision of pupil and visual loss in 6 days is less likely to be because of papilledema. And even if you glaucoma, there is no history of any headache or anything, and fundus changes in glaucoma is different. Even if you don't see the fundus properly, if you with the common sense you can answer this question as bilateral optic neuritis, because blurring of vision pupil bilaterally, and the given image was of blurring of the fundal margin was, I didn't get the exact image. So this answering, I don't think the image is not that must for answering this. If you just don't go into a confused nature, if you take it that headache and visual loss can occur in glaucoma, yes, obviously it can occur in glaucoma, but here it is like a headache, blurring of vision and bilaterally and within 6 days, and image of the fundus. So the fundal image is given. Glaucoma, you won't see an acute fundal changes like that. So you will see is a papilledema. Usually visual loss is not a classical feature of papilledema, and blurring of vision can present, but this much which is affecting is less, not that common with papilledema. And optic nerve drusen usually classically doesn't produce a visual loss. So, and papilledema and papillitis difference we have discussed in our neuro-ophthalmology session on papilledema and papillitis and papilledema. Last session, last slide was, I think this was a slide, the same slide I had kept here. So papilledema, the difference in the disc, it is red, and red with the marked hyperemia, 2 to 6 diopter swelling. You cannot make up the diopter and roll in the image, but what you can see is there is no bleed, and it is less marked edema, and you won't see much bleed or edema or all those things there. So, and visual loss is there, so those things favors more of papillitis. So I will go for bilateral optic neuritis as the option, because again here visual loss is not a classical feature of papilledema. That is enough to diagnose that. So neuro-ophthalmology, all the 3 questions asked were pakka practical clinically oriented question. So again in this exam you are seeing lot of practical, lot of clinically oriented questions. So next was neuro infection. There are 3 questions asked. First was HIV patient with a visual, again a clinical question, visual disturbance since last 6 months, left parietal occipital. This was actually an image was kept. And unilateral. So it is something like this. This was image. This is not exact image. Something like this. Just contrast, non-enhancing lesion. You can see that hyperdensities, and this is a contrast image. You can see the contrast here, but it is non-enhancing. That is what was given. And so it is a HIV patient with this one. You should, an asymmetrical parieto-occipital lesion, you should suspect a progressive multifocal leukoencephalopathy. That also we have discussed in our MCQ session on infection. This was the same image we discussed, and almost similar image. Parieto-occipital was given in the image slide also, but whatever I had given, I got was the same question I kept in the MCQ, just a right parieto-occipital, but the question asked was left parietal. That is only difference. So the question is basically to identify the image and think of a PML. That is the first thing you need. And you don't need much. If you read about the options, you will get totally confused because lot of statistics is being asked. But always think that the common things they will keep, that you should know. Something which practically important they will keep in the option. It occurs in the early course. That is wrong. Actually, HIV and PML doesn't occur in the early course. JC virus antibodies are commonly seen in normal population also, though that is, all these are statistical questions. You don't need to confuse with that. If you just remember, this is the same slide we have discussed, and we discussed that PML occurs when the CD4 count is less than 100, when the immunosuppression is severe. So by that time it is not in the early phase, it is in the later phase. So that is enough to answer this question. So it doesn't occur in the early phase, it occurs in the late phase of HIV. And to identify PML, I think this was the answer which was given. And to identify this, you need to have basic idea about PML. That PML is asymmetrical parieto-occipital and it is non-enhancing in the background of an HIV. But PML iris, which is associated with natalizumab, and that can be slightly enhancement. And we have discussed all those things in the session on HIV in the infection MCQ 2, MCQ 1 or 2 that we have discussed in infection MCQ, the same question. So PML is an infection of oligodendrocyte, and adult roughly around 55 to 85% as seropositive. That was the second option, around 70 to 80% as normal. So it is JC virus antibody is very commonly seen in this one. PML is caused by JC virus, which is a polyoma virus, and 85% of total cases are HIV. So it is very common with HIV, and it usually occurs in immunorecovery following heart, and particularly those with CD4 less than 100. So it is not seen in the early phase. They will be seen when the CSF CD4 count is very low, and CSF is normal with the mild pleocytosis. PML is due to immunocompromise. No contrast enhancement is seen. Contrast enhancement is seen when PML iris is there, and diffusion restriction on the leading edge is one more feature. No specific treatment is there. Mirtazapine, interleukin 7, topotecan are used for trials. All these are off-label trials. So these things we discussed in our MCQ. Then clinical picture of 3 days, fever, altered sensorium, and seizures. What is false? NCCT and CSF prior to antibiotics, steroids prior to antibiotics, and NCCT before CSF. So one more option, I just didn't get it, but the answer is there in these 3 options. So this is a patient with fever, altered sensorium, and seizures. So whenever there is a meningoencephalitis suspected. We have discussed in the module of meningitis, we have discussed towards the end where the treatment is discussed. The treatment of the antibiotic should be given within 60 minutes or 1 hour of admission to the ICU. So you cannot wait for an NCCT or CSF to get an antibiotic. If you cannot shift for, this is not a cutoff to start antibiotics. Preferably CSF to be get before giving antibiotics. But it doesn't mean that always you have to wait for CSF and NCCT to get antibiotics is totally wrong. I'm not sure what is the fourth option. Among the available options, this is a seemingly wrong answer. Steroid prior to antibiotics is seemingly correct because steroid should be initiated prior to antibiotic to reduce the inflammatory reaction at least 20 minutes prior to the antibiotics. And NCCT before CSF is not always a must, but here there is an altered sensorium seizure. When there is an altered sensorium seizure, focal signs, you should always get an NCCT before CSF because it can be a possibility of abscess that can herniate on doing a CSF. So that is something which is seemingly true. So among the available option which I got, I feel this is the wrong option. But if there is a totally wrong option is there, I am not sure, because preferably CSF and CSF should be done prior to antibiotic. Preferably NCCT should be done prior to CSF. But in this clinical scenario, you cannot get a CSF without NCCT because patient has altered sensorium seizures. And you cannot wait for long time, more than 60 minutes for antibiotics. So it should be better to go with this option among the available options. So again, this tells about the importance of management. Again, a clinical scenario. The focal signs, seizures, raised ICP, obtunded patients, immunocompromised, then imaging should be done before CSF. This is what we have discussed in meningitis session. We also told that within 60 minutes of arrival, you should give antibiotics. SSP, the false statement is, again, this is something which we have not discussed in detail about SSP, but I have told only two things which is important SSP while we were discussing about the prion disease. That is the same question came here. CSF measles antibody is used in diagnosis. Reactivation of measles is a reason for SSP. I cooked up these options. Only option which was given, which is the answer which I got, was a short interval periodic discharge as seen. That was the answer of this question. So the theme of this question is you need to understand the SSP EEG changes. That I have told. There are two things important about SSP. One is a CSF antibody and the measles antibody, and second is the EEG change. These are two questions they will ask in SSP, usually in all questions. So this is what we have discussed in our module of prion disease. A short duration periodic complex is seen in CJD, while a long duration is seen in SSP. If it is that periodic complex are repeating less than 4 seconds, you will call it as short duration. If it is more than 4 seconds, you will call it as long duration. So long duration, this is in Rademacher complex, long duration complex. That also, the name also we have mentioned in this same module. So long duration is seen in SSP. So the wrong answer is short duration. So again, the idea of the question is to understand two things. One is EEG. And second is the CSF IgG measles antibody. So these two are something which is important in the case of SSP, and remember, slow myoclonus occurs in SSP. These are three things which is very important in SSP. So that also, as we have discussed. So neuro infection, 3 questions asked, all were discussed, but all were, more important is, all were practical oriented questions. All were practical oriented questions. And all most were expected except that question from PML, which is not that quite commonly asked. Remaining were expected questions. ESF and treatment of meningitis, that is routinely asked. SSP is something is important in neurology SS questions. Most probably the EEG, EEG, Rademacher complex, and the CSF IgG measles antibody. These 3 things routinely they used to ask in different neuro questions. So that also is not that tougher and more practical question. Then spinal cord, there are 2 questions asked. One was a patient with lower limb weakness of lower limb and knee jerk is exaggerated, plantar is extensor. So that means knee jerk, the root value is L234. So the lesion should be above L234 and a sensory level at umbilicus. So umbilicus sensory level means T10. So lesion should be above T10. So options contains T78, which vertebra to look for an imaging. Actually, the exact options I didn't get. T10, T11 vertebra, T78 vertebra, and L1, L2. So this was the thing we discussed in our in our session on spinal cord anatomy. So this is at the vertebral level and this is a spinal level. So in T10, the spinal level is L1, L2. Here the patient has sensory level at umbilicus, that is T10 segment is affected. So the lesion should be above the T10 spinal segment. So the MRI should include a section above T10 vertebra. because T10 vertebra, the spinal cord segment is L1, L2. Clear? The T10 vertebra, spinal cord segment is L1, L2. So the upper cervical cord, it is same level. Lower cervical cord, add 1. T1 to T6, add 2. T7, T9, it is add 3. So suppose it is T10 spinal segment. So it will be located at around T7 spinal cord, spinal level. T10 segment of spinal cord will be located around somewhere around T6, T7 and the vertebra. So the imaging should include T7, T8. Vertebral image should be looked for is T7, T8. Actually, in fact, it can be any level above it if you think in a neurologist point of view. But from the options given below, all the options are below T7. You should at least image at T7, T8 level, because T7, T8 vertebral level, you will have a spinal segment of T10 will come. Because at upper cervical, the spinal level is same, but lower cervical add 1, upper thoracic add 2 or 3, add 2, lower thoracic add 3, and T10 vertebra corresponds to L1, L2. And you see L1 vertebra corresponds to sacral segment. If you take L1, you will see a sacral spinal cord. If you take T10, you will see an L1 spinal cord. So you are supposed to take a T7, T10 is the answer, because this question is based on the basic anatomy of spinal cord and the vertebral level and coordination with its spinal level. This is also something which you see practically when you see a practical spinal case which is kept for your exam. This is a routine question. So again, it is a pure clinical oriented question. So spinal cord 2 question asked, again it is clinical orientation is very highly clinically oriented questions, so keep on asking. Both were discussed. One was regarding the vertebral level, and the second question is actually the neurogenic bladder related question. That was actually asked in the peripheral nerve but kept in the peripheral nerve, but that question was directly asked in neurogenic bladder, because you need to know the bladder innervation. Again, it is very practical area. So the next question was again coming from the sleep. There are 2 questions asked. We are expecting to ask questions from the newer drugs as well as the disorder, particular narcolepsy. Again, the both questions for narcolepsy. One was 20-year-old male, sudden fall while laughing, immobile for a while, hallucination while waking up from the sleep. What is the diagnosis? Again, it is very clear. We have discussed it in the sleep session that narcolepsy occurs during the positive emotions, not negative. Not during the cry, during the laugh. Similar question, similar clinical scenario also we have discussed. And he has laughing followed by immobile, atonia, and then hallucinating while asleep. And what is the diagnostic test? MSLT is a diagnostic test for narcolepsy. We have discussed different types of narcolepsy 1, 2, 3. This is a slide from our discussion. Narcolepsy 1, 2 and 3. 1, 2 and idiopathic hypersomnia. Narcolepsy 1 has narcolepsy and cataplexy. Here he has atonia is there, and sleep paralysis plus or minus, sleep hallucinations. Hypocretin is decreased, and MSLT with less than 8 minutes sleep latency, and sleep onset REM sleep more than or equal to 2. Minimum 2 is required. So that was the next question was based on MSLT. Which of the following is false statement? If you have gone through this table, it is easy to answer. Should do an overnight polysomnogram. So before any MSLT, you should do a baseline polysomnogram, because before labeling as narcolepsy, you should rule out OSA or other sleep disorders. Then average sleep onset less than 8 minutes. So that is used for diagnosis of using MSLT for diagnosing narcolepsy. Next question is sleep onset REM sleep disorder in one sleep is required for diagnosis of narcolepsy. If this option was exactly this, that is answer, because narcolepsy requires 2 sleep minimum, 2 sleep onset REM. This is an REM early onset. Narcolepsy where your hypocretin is less, so that hypocretin is a wake promoting hormone. So what happens is you will get early sleep because hypocretin is less. So REM is onset is early. We have discussed about the pathophysiology, all those things detailedly in a sleep module. And that is something which you request if you want to explain for again, it requires lot of time, because sleep pathophysiology is something is very complicated. We have tried to make it much simpler. If you watch the basic modules, then go for the sleep disorder, you will understand it better. So that was the importance of narcolepsy. Again telling you that the importance of sleep disorders, particularly narcolepsy and the newer drugs is important in sleep. The question asked both from narcolepsy only. So next question is just completely new for our modules, because this is something which we have not discussed. When you will tell the CSF pressure is raised. But this is a very again a practical question, because all the CSF, when you are checking the CSF, especially for NPH or idiopathic hypertension or during a meningitis, you will measure the pressure. So how much millimeters of mercury is significant? So this is 150 to 100, 150 to 150, 150 to 200, and what you remember is something around 180 is normal. less than 180 is normal. But when it is more than 200, you will call it as raised ICP, because up to 200 can be normal, particularly in obese patients. So especially when you are evaluating a CSF for IIH, you should keep in mind above 180 to 200 can be kept normal if its patient is obese, and if there is abdominal pressure is high, you can have a mild raise. So the range, this is a direct statement from 8th edition Bradley, brain edema and disorder. A normal CSF pressure ranges from 80 to 180, but that may go as high as 200 in an obese patient or those who are not relaxed. So you should take a more than 200 as abnormal. So that also, the question was slightly outside our discussion topics, but this was directly from Bradley and directly a practical oriented question, because you would learn everywhere 180 is normal. You have an attempt to put it as 150 to 200 as abnormal, but more than 200 only you should take it as abnormal. If the option was like that, if the option doesn't have this and the value this and this, but the value above 180 is that, you can go for that also, depend upon the option. But actually, more than 200 is supposed to be taken as abnormal. The next topic is cerebral ataxia. 2 questions came, and actually one was expected. I was telling that SCA 1 question will come. I didn't get the exact options of this. Which of the following is false? But I got the 3 true answers. One is SCA 3 extrapyramidal. SCA 3 is Machado Joseph, which has extrapyramidal. SCA 7, we have learned that SCA 7 has visual loss. SCA 2 has slow saccades. That also we discussed. So the 4th option might be the wrong. I exactly don't know what is the 4th option because I didn't get that option. But without knowing that also, if you know the 3 right answer, you can go with the exception. So the questions were all the questions. If you see the most of the questions which looks like tough, but what they meant was, if they are given 4 options, 1 will be something hi-fi and remaining 3 is something which you know. And if you know there are 3 options, and you can go with the 4th by excluding the remaining 3 options. So that is the basic idea of the examiner who has kept the exam. That is what I think is. Some of the tougher questions, most of the tougher questions comes like that. If your question seems to be tough, there will be some clue in the options. So this is a slide from our session on SCA. SCA 1 has pyramidal, extrapyramidal. SCA 3 is low saccade. SCA 2 has saccade. SCA 3 is Machado Joseph, which has 3 type of variation. One is with extrapyramidal, and SCA 4 has pain. SCA 5 is Lincoln's ataxia. SCA 6 is downbeat nystagmus, pure ataxia, benign SCA, and SCA 7 is macular degeneration. So with knowing this only, you can answer that the 4th option, whatever it was, that was a false statement, because other 3 statements are true. So slow saccades classically in SCA 2, but it can also occur in SCA 1 and 3 and 7, but it will be late onset, early on. This is the same slide from our discussion on SCA. And SCA with the kinetorigid is SCA 2, SCA 3 and 17, because they are associated basal ganglia involvement and they are associated extrapyramidal involvement. But some movement disorder can present with SCA 7 and 17. Classically 17, 7 also sometimes they can have chorea and myoclonus. Tremors are associated SCA 12 and 20. 20, remember, palatal tremor is important. So we have gone through what are the importance in each SCA in that session. Each SCA, what is the most prominent features, and this is different types of Machado Joseph or SCA 3. See, SCA Machado Joseph type 1, Parkinson dystonia. SCA Machado Joseph type 2 is ataxia. Type 3 is ataxia with amyotrophy. This, as we have discussed in detail in our module, I am not going into details because it will take a lot of time. The next question was subacute combined degeneration. Which among the following is false? This is something which slightly outside the module because we are not discussing this detail, but it is easy to answer. See, if we have discussed that subacute combined degeneration can be associated with the vitamin B12 deficiency, hypocupric, vitamin E, all these can be associated with subacute combined degeneration. So it is associated always with anemia and macrocytosis, wrong. Sometimes it can be associated without anemia and macrocytosis because the causes can be not even B12, vitamin E, hypocupric, all these can present subacute combined degeneration. So that is obviously looking like wrong. So that is the answer of this question. Vitamin B12 supplementation will stop the progression. That is obviously maybe true if it is vitamin B12 deficiency. Posterolateral cord is involved. That is also correct. The 4th option I didn't get, but obvious wrong answer I feel it is always associated anemia and macrocytosis is wrong. So cerebellum and ataxia, there are 2 questions asked. One was discussed, one was about the SCA, which we will discuss. One, even though we are not discussing in detail, but I think it was able to answer. But again, it is everything was more practical oriented questions. Most of the questions were, and many of the questions were from the expected areas only, not from the unexpected areas. Most were from the expected areas. So these were the questions asked. Total 46 questions I was able to recollect with the help of some of my students. And I am thankful to them to get me the questions. And one is again stressing the importance of stroke. stroke is one area which is lot of questions came, and I will try to stress the importance of clinical, one is clinical questions were asked, lot of clinical questions were asked. Second thing is there has been lot of questions asked about updates, especially treatment part, newer drugs, and most questions I feel like most from the expected areas only, not from the unexpected areas. And again stressing the importance of newer updates, newer drugs, as well as the clinical. And the stroke is particularly important. Even epilepsy is one area they have gone into little bit depth about childhood epilepsies, epileptic encephalopathies. They kept on asking 2 questions, and one from the drug, and so that is epilepsy is something which they have went depth. From the sleep they asked 2 questions, both were from narcolepsy as expected, but I was expecting some question on the newer drugs of sleep. I hope one question will come in the NEET from the newer drugs of sleep. Then peripheral neuropathy, 2 questions asked. One was AL amyloidosis, it was little out of the box, but still you can able to answer if you apply some logic. And second question was actually from the bladder. Urethra, the question looks like weird, but when you go and check your bladder, which is like nerve supply of bladder is something all medicine people will study for their long case, because paraplegia is one long case for medicine exam. So that was about peripheral neuropathy. Muscle, I was expecting some question, but there was no question asked from muscle. That was something unexpected for me, but I think muscle, again it is important, you cannot skip muscle, because especially the dystrophies and the inflammatory myopathies, particularly the antibodies, are our favorite areas. So then coming to neurophthal, there are 3 questions asked. Neurophthal is something which they have asked like something very practical, very clinical, like they have put junctional scotoma, and they have put some fundus images. And fundus images I was expecting, but even without the fundus images, with practical knowledge you can answer that. Then cognition, dementia, again Alzheimer's, the newer drug they have asked. And the cognition, some of the slightly deeper neurophysiology like mesolimbic pathway they have asked. Then hypokinetic and hyperkinetic, there are a few questions out of the box, but they were all expected only, like Wilson disease, even though without image also you can answer, without knowing much about Wilson also you can answer. Then not that tougher questions. Then stroke was one area, there are 4 questions out of the box, and there are new questions came, and but all were from Harrison tables, and that stressed the importance of Harrison tables, as well as at least about the major trials, and very practical oriented, very new updates. Also scores were asked, so that is something which you need to understand from the stroke, and images were kept from stroke. Epilepsy is little bit depth they asked, like I feel like for a medicine fellow it is slightly deeper, because they are gone to pediatric epilepsies, 2-year-old child and all. Then but it will be not that tougher questions. And headache, 2 questions are expected questions from erenumab and retinal migraine. And demyelination, 2 questions asked, that also newer update. One is finger chew criteria, and second also related criteria. And I was expecting some question to come from the demyelination about the drugs, but I think they will ask in the next exams, they will come some questions from the newer drugs. MS and newer studies in MS are important. And cerebral and ataxia, 2 questions, both were expected. One is CA and other one is subacute combinations, both were not tough. Spinal cord, in fact, 1 question plus 1 from the bladder, both were actually very practical questions. Neuro infection, 3 questions, 1 was bit tough, HIV PML was little tough because you have to identify it as PML, but we have discussed similar case in the discussion. Other 2 were relating meningitis, which was easy. Mnd and Nmg, we are expecting question on SMA. There are 2 questions related to SMA came. One was nusinersen, second was Risperidone. I was telling that onaseminogen they won't ask, because it has been there in the newspaper for a long time. And Nmg also expected, as expected from congenital myasthenia crisis, that was expected question which came. CSF pressure was a new question, and genetics, 1 question was that we don't know the exact options, I didn't get, but still I think that was relatively answerable if you know the trinuclear repeat disorder. And that was what I got. And if there is any suggestions or any corrections or any new questions which I missed, you can put in our Marrow Facebook group, or you can mail to Marrow directly. They will forward it to me and we will try to answer it. And among the 46 questions which has been asked, the 46 questions which has been asked in the exam, which I got 46 questions of neurology from the exam. And demyelination, there are 2 questions. Out of that, 1 question, that is Wingerchuk criteria, we have not covered, but Wingerchuk we have covered the criteria, but we have not put the name. That's a newer one. And headache, 1 question about erenumab, we have discussed about erenumab, but we have not discussed side effect. But even if you don't know the side effect, with knowing whatever we have discussed, you will be able to arrive at the answer in that question. And stroke, there are 13 questions, 4 were not discussed, and most were scores, and 1 was directly from Harrison, and that is one area that a new question came maximum. And hyperkinetic, 2 questions, like one is Wilson's, even though that is out of what the image we have not discussed, but the third image also you can answer. So I feel like, and second question was regarding the tics, that is a bit confusing, but still I think both of them was little bit answerable. And cerebellum, one question was like subacute combined degeneration, but that was easy and straightforward question, so that was not tough. So I feel the stroke and one question hyperkinetic was a bit tough, and again epilepsy. These are the 3 areas I felt among the question papers that was a little bit tougher for according to my assessment. It depends upon each person's assessment, but for my assessment, these are the areas which are not covered, completely covered. So total 4 plus 2 plus total 9 questions came not directly from our modules. So total 37 out of the 46 were directly from modules. Some few questions directly, whatever we put like epileptic spasms and the initial investigation, all those directly came directly from our module, directly from what we have discussed. And 9 questions were not directly from the modules that we have discussed just now. Out of that, 2 has been discussed during the modules, and you can answer those questions with whatever we have discussed. And even one question about the primary CNS angiitis you can answer to an extent, but I will not include that. But remaining 2 questions you can answer whatever we have discussed, using that you can answer that. And remaining 5 are totally out of new question. I will include that 5 as out of related new question. So 41 out of 46 you can answer if you have gone in depth to our modules, in detail about modules, and 37 questions are directly answered. That was what among the questions which I got, that is my inference about this one. So again I want to stress that the important for next question also, next exams also, the clinically based latest updates and the newer drugs, especially the monoclonal antibodies and the newer genetic drugs, genetic treatments. These are very, very, very important. And especially stroke, again in any exam stroke is important, and epilepsy is important. And images comes either from stroke, epilepsy, or from the your hyperkinetic movement disorders. And the fourth area I want to stress is, even though muscle is not asked, but I feel either inflammatory or from muscle dystrophy, there will be some questions will keep on coming. So that was about the INACT recall, and I hope you have done well. And if there is any queries, you can put questions either to directly to Marrow or to the Facebook. Thank you all.